Select Committee. I'm Councillor Lisa Knight, Chair of the Adult Social Care and Health Select Committee. I will be chairing tonight's meeting. The event is being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussions taking place. I'd also like to welcome everyone here and those watching on YouTube. I think it would be appropriate for us to start with 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Now move to the meeting. We've had apologies for absence from Councillor Graham, Councillor McAdoo, Councillor Dempster. Judith Davey from Health Watch has also sent apologies for the meeting. Declarations of interest. I have no declarations of interest to make regarding the items on the agenda to any members holding interest. The minutes have been circulated at the last meeting on the 12th of October. Does the committee agree to sign them off correct? Or as the correct record? Agreed. Move to the first item on the agenda, North West London Palliative Care Services. This report has been brought to us from colleagues in the North West London Integrated Care System. Here today to discuss the report with us is Robin Doran, Jane Wheeler, Philippa Johnson, and Dr. Lindsay Williams. So welcome you guys to the summary for the report.
Thank you. So I'll kind of introduce. I'm Robin Doran. I'm the SRO for this programme of work across North West London. I was going to start by reminding people when we came here in March this year, but I'm aware it's a whole new committee in terms of, but I have no doubt that you've been briefed and that you've read the report. But we did come in March and had a very useful conversation with your colleagues. And from that, carried on working quite closely with RBKC, patients, carers and families and other stakeholders in the area, understanding how we can improve the experience of all of the adults that we need to treat who use specialist palliative care services. We're not going to go through the report because we know we've got kind of 5 minutes to introduce it. But I've got to make a couple of quick points before I hand over to Lindsay and Philippa to pick up on a couple of key areas as well. Since we last met, as I said, we have carried out quite extensive engagement across North West London, and also, in particular, we've heard from some of the residents and collected stories and case studies from residents, in particular in KNC and other areas as well. And there are some of the stories that are on the website. It's really important that we listen to the experience of the people that we serve, and so that we can learn from those experiences. We've carried out literature reviews across the country, particularly looking at areas such as learning disabilities, homelessness, and people aged 18 to 45, because those were kind of groups that we knew were underrepresented in the conversations that we've had. So we're kind of looking far and wide around best practice, but also we're looking at what else is being done in terms of literature. We published an interim engagement report in May, and we're going to publish a final one shortly, which gives feedback in terms of what we've picked up so far and the ongoing work that we've been doing. Engagement will carry on though. I'm going to hand over now to Lindsay, who's going to give a perspective from a doctor's perspective.
Thank you, Robin. So I think for us, it's really the listening point of this entire programme. And it's not, so what we're hearing is that patients want, 24/7 access to good care and support. But it's also the softer intelligence, the softer things that they want support with, like supporting them with faith and their cultural needs, and what that means. So it's for the teams looking after them, just because someone has a certain religion, but what does that religion mean to them? What are they looking for in that end of life pathway? We're also looking at, when we've spoken to them about when they want to change their minds, that's come up a lot, and the rapidity of changing minds. We know that as things change at a point of crisis or rapidly, minds change. And so we need to recognise and include that moving forward. And then it's just that, like I said, it's the listening part, and understanding what does it all mean to patients, and what does that mean to us as professionals. And so what we do is, what from all this feedback, and it's, as Robin mentioned, it's ongoing, which I really like. It's not just this is closed book, you had your chance. It's continuous throughout this entire process. And we have a model of care working group that I chair on a weekly basis, and the membership is with patients, carers, those with lived experience, as well as providers, so healthcare professionals, health and care professionals. We've had over 20 meetings. It's longer than I thought it would be, I'm going to be honest. When I said, yeah, let's do this, let's co-produce, I think we've got 12 members of, lay members, non-medical or care professionals as part of that. And the reason why it's taking longer is because what we need to do is get this right. I think that we can rush this, and I've seen this. I've been in this game a little while now, and I think you can rush things and get a quick tick box and quick wins, or you can take your time on this. Make sure that you've listened. Make sure that you've covered what actually matters, and that's what I think it's important to reference about. Yes, there's that 24-hour care and support, but they also want the rest of it. And I think that that's the part that actually I'm most interested in. I think the care and support part is you commission things to be done 24/7. I think it's all the other elements that need more time. And so that's where we're at the moment. I think that's
Yeah, so I'm going to ask Philippa to just say a few things, particularly in relation to Pimbridge, which we know is a particular issue for the Royal Borough.
Thank you, Robin. So, so Central London Community Healthcare is responsible for the provision of the Pembridge services, and that's the inpatient unit, which is currently suspended, the day hospice, and the community nursing team. So they're all called Pembridge, and sometimes that gets a bit muddled when people are talking about Pembridge and Pembridge being suspended. So the inpatient unit is continued to be suspended whilst the review continues. So we have agreed that the future, nothing will be decided about the future of the unit until the review has played out. The other parts of the community service are operating, and the community team in particular have been very busy. So in the report with some activity data which shows that they are busier than ever and working really in people's homes. So the day hospice was part of that suspension. So when the unit was suspended, and then we used the unit inpatient beds for COVID surge during the first and second wave of the pandemic, the team moved out to another part of the estate at St Charles. And then we have been recently doing some work to get that team back in and getting the day hospice back open. But all the services that the day hospice provide have been provided either virtually or face-to-face in people's homes, and we've got the activity data that shows that. So we're confident that people's needs are being met. It might not necessarily be in the old day hospice space. I think one of the things, just to pick up as well, I know there were some concerns about building work going on in the unit, and that is, as we were bringing the team back in, the landlord, NHS, had to do some work on the building around pipeworks and various other estates issues to get the estate back up to scratch to allow the dean to move back in. That is due to be complete on the 17th of December. So we are due to stand up the day services face to face very shortly after that. So obviously the work just has to complete. There has also been some moving of desks back into the ward area, which has been temporarily used for the community team as a base, whilst the ward isn't providing the inpatient unit. So really aware that the strength of feeling from local residents about having the hospice Pembridge inpatient unit available is all feeding into the report and has been heard very strongly, and obviously will be part of the considerations, especially around the qualitative factors and people's travel to other units as well.
Thank you. I'm going to take questions from members of the committee first, by councillors and members of the staff. Firstly, thank you for the report. I just wanted to start by saying it probably wasn't the update that this committee or a lot of residents wanted to see at this point, considering how lengthy the process has been. And I just wanted to get a kind of understanding of the timeline as to when you think there might be some crucial decisions made, or how long the consultation period is going to take, and also to explain to people what the main different options of reopening the inpatient centre are at present and how feasible they are. And then, sort of aside from that, which is, we'd love to know what focus on. I mean, if Pembridge doesn't reopen, just on top of that, what do you see palliative care looking like? RBKC in years' time?
Do you want to take timescale?
Yes, so I think Philip made a really good point about doing this right and getting the right outcome and that taking time, and it's a real tension we've got between coming to a resolution for North Kensington residents and the wider patch of access to Pembridge services versus doing something which really explores all avenues. And we would have liked to have done this faster. We talked to the patients and the carers who are on our route. They think we're doing it the right way in terms of giving the space for those ideas to come out. At the moment, we are hoping to publish what we think is our model of care, to do not formal consultation on, but to discuss and engage with people at a borough level into the new year. So we're hoping now by the end of January that we can publish something. Now, there's several challenges around being able to work up much more detail beyond that. Obviously, physical access is really important to people, for relatives and carers to be able to travel to see their loved ones, and there is methodologies by which you can compare different travel times, and so we can be really transparent about what populations are impacted and what populations across the whole of North West London. But you'll also be acutely aware that we're right in the midst of bus routes changing, and so the timing of us being able to assess the impact of those is just a bit tricky at the moment. So we think we'll therefore be able to publish a model of care which sets out the ingredients of what our group, with the leads involved that Lindsay's talked about, the professionals and the residents, and having discussed that at local boroughs in the new year. But we do think then have to do more work which will say what the options are once we're able to do some more of that. Some of the factors which we can compare options, because there will be comparisons and trade-offs. I think what we said to your colleagues back in March was we also want to be really honest about there may be routes where we can't come to a solution for Pembridge, and coming here, and as much as we know that isn't what people want to hear, coming here and saying we're putting all our eggs in that basket would just be disingenuous, because the provider has done a stack load of work on recruitment. So we've done 4 rounds of recruitment without success. We've talked to all of the hospice chief execs and medical directors about impact. Could we do a network of consultants? And we haven't found a viable way forward. So whilst we are still looking at what that would look like to open Pembridge as the consultant-led unit that it was of old, we are also giving as much weight to exploring other options which get that access in for residents. And particularly when you see the themes that come out from residents, there is so much about that care in their own home, and also a lot about the needs. If you haven't got the most complex needs, if maybe you have a more comfortable death, or to predict you have a more comfortable death, that wraparound care, which includes the clinical input, the psychological support for family carers, and the carer time that you get from hospice at home type services, really beefing that up, making sure it's culturally competent, making sure that it really responds to individual needs regardless of age or other needs, is the theme that we need to get right. And probably if you look nationally and internationally is where a lot of the innovation is, about how how you support people. And people have heard around virtual wards and how you really use that opportunity to support populations and support individuals and those who are supporting them to deliver. So I think on that, that's what working to a model of care in January. We'll then need to do more work about kind of what that means for different people across North West London, of course, this area. But we are putting as much energy into alternatives if we're not able to open up Pembridge as a consultant unit, because we think that is the way we maximise our chance of improving experience and outcomes for people in the area rather than putting all our eggs in one basket.
And is your recruitment process still live for Pembridge?
We last went out to advert in 2019, so before the pandemic, for consultant posts, but the more recent work was 2021 when we were looking across providers to see whether we could come up with a collaborative effort to fill those gaps in a different way, and really trying to hook in, especially with acute providers, just to give that kudos really for the consultant in acute provider as well. So as Jane said, we didn't manage to come up with a solution there, so they in that position really. So, and it's very hard to imagine that we would attract somebody with the current level of uncertainty really about the future of the unit. So I think we've got to work through that model of care and then work through recruitment in parallel.
I wonder, Lindsay, if you could do a kind of a pin picture of the kind of outline and model of care at the moment.
I think so. I'm going to be very honest with the committee. So I'm a GP in Brent, and so Pembridge affects our population, my patients, and absolutely my patients because I'm a Kilburn GP. So definitely in my patch. So I've gone through cycles of wanting it open, wanting those beds, and being part of this programme of work, and that all started in 2018 for me. So we did a bit of work, we did more work with Central, I went on mat leave, we've come back, we're now doing a collaborative of North West London. This is probably this model of care working group on a weekly basis with the patient representatives and the carers and the lived experiences, and I have my own personal lived experiences as well of hospice care as well as professional, is the first time I've actually thought about, is it just the beds that we want, or actually are we looking to improve care? And it's the first time that I've really realised that they're two very different things actually. We think if we just get bed numbers up that care will improve. It won't. That is not the case. And actually from all of this work that we've done, it's been incredibly eye-opening. And I think everyone will have seen, I mean obviously it's in the news actually this week about palliative care, but it isn't something that people like to talk about much, particularly when it does go wrong. Even people don't want to talk about it because it's such a horrible memory when it goes wrong. But we have done some incredible work and we have teased out these stories. And actually, it's not just about beds. It's actually about access. It's actually about, like I mentioned, the cultural sensitivities. They want people to understand what it means for them. They want to be able to discuss changing their mind and what their options are. They want to know their options early. So the patients that were part of this model of care group, some of them didn't know that the community palliative care team could do more than one visit a month or something. You know, they were like, oh, I thought that they would just, you know, come in every now and again. And we were like, well, no, it depends on your needs. You know, if you needed them, oh, well, that wasn't explained. Or and actually a couple of them have even shared some incredible statements that they now feel empowered to support the members of their community in how to access, because they feel like being part of this process, they're now aware of what they can and can't access. And so their minds have changed on beds and what the Pembridge beds, and I think it's opened up a whole nother opportunity here to improve everyone's opportunity of end-of-life care and what that means. And that's why it's taking so long. And I really have, I came into this going back from mat leave and was like, God, we're still here. Like I just, you know, and I know that COVID was in the middle, but where we're at now is brilliant, and I feel really reassured clinically that we're going to make a difference, because I feel like we're in the right place now. Before, previously, it was just focused on beds and inpatient beds, and now we're looking at this the bigger picture of care and what that means, not just inpatient bedded unit care. So I hope that that's, and we talked about lit reviews. We've got some great data. We've done some really horrible number crunching, which is definitely not my strongest point, but we have colleagues that have been supporting with that, thank God, to make sure that we're not just doing it based on people and people saying things. We're doing it on actually numbers and and contacts and the data that supports it. So I hope that that's given a bit more of an understanding of where I'm at, because I feel like I've been brought on this journey as much as you all have, possibly around the same time as a lot of our members of the public actually, because I've been a GP in Brent for longer than that. So I was there when it first suspended, so I've been there on that journey.
Just before I bring Jane in, I think the other thing is that beds are obviously important, but it's about choice. And I think it's about people having a choice to die where they want to die. And if they want to die in a bed, then that choice is available to them. And that them and their family, and as that's needed. But as Lindsay said earlier, that changes sometimes. Sometimes people want to be in a bed and they want to go home. Actually, they might be at home and them and their family decide they can't cope anymore and they want to go into the bed. So there is something about us having a range of options that includes 24/7 support and access to somebody at the end of the phone for carers as well, as and when people need it. And beds are definitely part of that, but they're not the only answer. And I think that's the point I guess we want to make. Jane, you want to make some?
You've made my point.
Gerald and then on to Mona, just
Okay.
because I think he wants to comment.
Obviously, the more options you get, the more complicated it becomes in a way. You're getting quite close to making this. What are the crucial factors, the 2 or 3 crucial factors that will determine whether it stays open or it doesn't stay open?
So through a lot of engagement, we published our first document in this process was an issues paper with 8 issues that set out what mattered to residents. And they are really our litmus test about what we need to do as options. And I'm now going to show that I can't quote all 8, but what really jumps out was workforce. We have a national workforce shortage of specialist palliative care staff, so we've got to focus on deliverability. Always having a plan which says we are contingent on a workforce that we have not been able to recruit so far is that definition of madness, doing the same thing and expecting a different outcome. So workforce was one of the burning platforms that we needed to address. This is not a cost saving exercise, so we are not looking across North West London to save money doing this work. We've also got to be mindful that it is also not a investment in lots more better facilities. They don't exist even for the staff to use. So there is a financial element here about the financial sustainability of the system without any savings associated with this, but we have to take that into account. There was another issue which was around that individualised needs for different populations, particularly the younger age group. We haven't talked much so far about care homes. For many residents, care homes are their usual place of residence. They are where they would expect to go home to, not private residents. How do we make sure those are supported? But that's clearly our older residents, not our younger residents. I've only managed 3 of the 8 issues, but that is.
But what's it going to boil down to?
It's going to deliverability. Because if we stand up and say, we're putting all of our focus on reopening it, and that is not something that we have any evidence that we can deliver, that isn't being fair to residents, because that prevents us focusing our time, energy, the workforce that we do have on supporting people in care homes, on developing new models around nurse-led care, on hospice at home, and increasing that into people's own homes. So
Deliverability is going to change over time, isn't it? There might be a staffing issue now, and in 5 years' time,
absolutely
the staffing issue changes.
Which
So.
is why we're looking at a five-year minimum plan. But when you look at the population projections coming through and the unmet need around palliative care, that puts pressure 12% into the system in terms of what you need just to sort of stay with the current delivery model. So we also need to take into account that creates another workforce pressure. And so you're right, we can develop different models for time because we can work towards them. But a palliative care consultant, we're not going to grow more palliative care consultants across the country in 5 years. It's a much longer term plan than that. So there is a sort of balancing act of what we can do when, and we've been talking to the group about quicker wins. So what can we do in the shorter term? We can make supported care homes a lot more robust. We have some areas which don't have the same hours of service coverage for example, hospice at home and access to single point of access for advice and support, we can fix some of those things in the short term, and then we can plan for other models of bedded delivery over time. But I think we just always need to try and understand what will change to make Pembridge open, because saying us wanting it is not going to be a delivery.
And it's a North West London review. This isn't just about, and I know obviously we're here and you're very interested in what's going on here, but equity is really important in terms of the communities we serve. And you as a borough know more about that as many others do. North Kensington, areas that haven't been particularly served well by the health service. We need to make sure that those different communities are having access to the full range of services, and many of them haven't. They didn't know about them. We weren't that accessible to them. So there is a piece of work around how we're working with those communities that have been underrepresented in all of the services that we provide in the community and inpatient.
I guess the question relates to what we just heard earlier about, I still want to try and understand what the obstacles are to that deliverability. But also the question that I had was also about bed capacity, because the report talks about that there's consistently been sort of empty beds across North West London, and I was just wondering what impact the closure of Pembridge has had on that. And specifically, what if we know, if we have an idea, I'm sure you do, about the number of patients who would have been referred to Pembridge and needed beds there that have been sent further out, so how many that they have, specifically what the experience of their families were, and yeah, just obviously bed needs are going to fluctuate, but there's no doubt that they're going to increase with an ageing population, and there's always going to be a proportion of that 12% increase that's going to need beds. And as I guess thinking about our residents, they are very concerned about the closure of Pembridge. I know that's not the full picture of how palliative care is going to be delivered, but having beds close by is really important, especially for some residents in the north of the borough who don't have the capacity, and the families don't have the capacity to be able to look after them at home. And also those individuals, sort of an elderly population, that's going to living alone. A higher proportion of elderly people are going to be living alone in the future, and actually dying alone at home might not be appropriate for them. So yeah, I totally get that bed capacity the beds haven't been filled. But has that changed in the last 3 years since?
I guess we've also got to factor COVID in it. So it's been a bit of an atypical time because we've had COVID in that period. So a lot of beds weren't used because it was actually safer in lots of ways to keep people at home.
Right, okay.
And that was generally around all kinds of specialties, not just around us.
So it wasn't that the need had gone down.
No,
the referrals.
No. And I think more and more we looked at that. I guess what it's made us do in terms of the way we deliver healthcare is we're delivering it differently. We're actually delivering much more in people's home than in other places. That is the way the model of care is going anyway in this area, but that's for a lot of the healthcare that we deliver in the community, be that physical health or mental health. There's much more work around how do we wrap around people in their own home as and when appropriate.
A lot of that, just to jump in on that, a lot of that care when we've done the engagement sessions is really about access to district nurses who do the bulk of the end-of-life care, actually, without getting to the very specialist end, and people's GPs. So I think that's what we heard, and when we look at our data, because we're a provider of the district nurses as well, who will take a lot of that work on, that activity is higher than ever. So, and that is, I think that COVID has shifted that to be more normal to have that level of care at home. So I think that's a general trend, isn't it? And if we could do more of that and people are comfortable with that, then that tends to be very welcome. Obviously, you've got people who are living on their own where it's not suitable, but I think the idea is to have an offer that meets everyone's needs.
And a range of bedded offer, including in care homes. So how do we, because actually it may be that there's because of the reasons that we've talked about, a limited number of specialist palliative care inpatient beds, but there's a lot of care homes that we could wrap our services around and go in and support them, that are frequently people's homes. You know, so people have the choice to die in what is their home, and that quite often doesn't happen. People end up in acute hospitals because those care homes are not supported. We don't support them in the way that they probably should be supported. So we're looking at that as part of the model as well. And definitely we're looking at the numbers and the projections to make sure that we have enough beds for both the growth of the population, as you said, in terms of the needs, but also, as you also said, you know, many people are getting older and dying alone. So there's something about what's best for them and how best can we support those people. And it may not be at home, you're absolutely right.
And we are looking at, in the model of care group, the discussions at the moment are really looking now at, so rather than delivery, we used to look at delivery of inpatient, delivery of community, and as Jane mentioned, we're talking about the equity and levelling up. So that came from that discussion. But then actually what we really came to a few weeks ago was that actually our patient representative was saying, why aren't we focusing on the need rather than what services can and can't be delivered? Why don't we look at the need of the patient? So then what we recognised was actually we need to look at that less complex need, like you were mentioning about those living on their own. They may not have a complex specialist palliative care need. They may not have something like recurrent nausea or uncontrolled pain. They might have a challenging situation at home where they just can't care for themselves, or they now, like you said, lonely. And so it's about looking at the different types of beds and care that you can do. So that's where we're moving to. So you were talking about the challenge, like what can we see as the obstacles? And actually, I think one of the negates of the obstacles is actually different types of beds and what do they look like. And we're looking at some really good, models nationally. So Robin mentioned we're looking at best practice, and there's some brilliant work going on with not just within care homes, but so these enhanced end-of-life beds, and I think that's the flavour that you'll sort of get from that model of care moving forward. It's inpatient unit, yes, it's specialist palliative care community, it's hospice at home, it's levelling up, but it's also different types of beds for patients and what they want, and being again rapidly adapting to the need, to the wishes of the patients and to the needs of the patient. So it's a really interesting, you're talking about it, and I think you're talking about other types of beds, and I think that's important. That's exactly what we're considering. We are looking at other types of beds and what they look like.
Thanks. And do we have the question that I had at the beginning, just those numbers who did need diverting on?
It's about 40% of the pre-COVID activity we've been able to track have gone into another inpatient unit. So clearly, some of that difference is a result of COVID and the patterns which were different, and we had various times when inpatient units were closed due to outbreaks, or so it's a false position of need.
So you can assume the need for those beds would have been much higher if we hadn't had COVID?
Possibly. We've seen some of boroughs which aren't impacted by Pembridge also go down over that period, as we've also seen an increase in community contacts. So it's quite hard to draw conclusions based on the last 3 years, but I think we all do know that there are a set of needs for local provision in North Kensington which aren't currently being met. How we size that is quite difficult based on the last 3 years' data, but I don't think we want to shy away from a recognition of the importance of local access for that population. I think the points we were just making about, yes, we can continue to look at what would it take for the Pembridge unit to reopen as it was, but it also feels right and appropriate that we're looking at other types of models and the timeframes that we can deliver those in for other kinds of bedded care.
And obviously, sorry, you mentioned that experience of families, and that's something that I've been looking at, actually working with our engagement colleagues who support me with that. So we are going to reach out to the families or those individuals that have been offered alternative inpatients, just a nice soft open questionnaire that they can either call us, they can write to us, they can text us, they can email us, giving them an opportunity just to share their experience and their family's experience of that. So we haven't got it yet, but it's something that I'm very keen that we do, and it's going to be happening in the next few weeks.
Could you share that information with the committee? We have it. Also on page 13, I think, You stated you plan to undertake research to understand if the service closure of Pembroke has resulted in a large number of patients wanting to access inpatient beds. And I think it'd be really great to understand when this research is going to happen and when it does, if we could see.
That's part of the conversation.
Yeah, if that's part of that,
yeah,
that'd be
yeah.
fantastic. Thank
Yeah.
you.
Yeah, so thank you for coming to this about this, and I mean this has been going on for quite a while now, and I really do appreciate that there's COVID and it's a complex issue and there's lots to think about. When is this actually going to be resolved? I mean, the model of care, really listening and understanding that's already great, but people need that support now and they need answers now, and if they can't. There's a lot of uncertainty, and I think for us, we want to give our residents certainty, so when are we going to be able to do that?
So if we are making what considered by this committee to be substantial service changes, we will require to do a full consultation, and that will take us the best part of 9 months once we've got options worked.
That's if we're doing substantial.
That's if it is considered to be substantial service change. Now, that is, I think, a really helpful debate to start having with colleagues here and, of course, in the other councils. Some of the other councils across North West London, maybe where they don't see this as substantial change because there's not a unit on their patch, will say, for goodness sake, let's just do this as fast as we can do, because those quicker wins we're talking about, those things we'd like to be able to do sooner, we really just want to start being able to make those improvements as soon as we can. So I think once we've seen the model of care and how it's articulated and whether that feels like an improvement for your population or a substantial service change which requires consultation, that once we've got the model of care out, that will be the debate on timeline, whether we need
And
to.
that's February, isn't it?
Yeah.
So I mean, it could be well over another year.
I
Yeah,
think-
subject to what
Yeah.
the model of care is and what you want us to do.
But those are statutory timelines around bringing
Yeah,
forward.
no, I understand that, but I guess if you're a family that is dealing with some of these issues, it just doesn't feel very reassuring. And I mean, I worry that people aren't getting that support, and having something in the community I think is really important as well, and being part of the community actually. So by the time we get to resolution on this, it's going to be kind of 5+ years really.
I don't
It's
think
a
I
very
can
long
give you
time.
any more assurance around shortcutting that. We have to, once we're clear that if we're going to consultation, which it feels very likely, conversations in some of the other boroughs, then there is a timeline that we will need to follow.
But in the meantime, we've got to make sure that the residents are getting what they need as in terms of the flexibility of what we can deliver now. And if there are any issues and any concerns, then we'd want to know about that. If you've got any residents that you don't feel are getting what they need and in the most flexible way that we can deliver it now, then we'd want to hear about that so that we can pick that up immediately.
And I think we said this last time we were here as well, if there is a solution, and I know you were recruiting for a community consultant last year, I remember last time we were here, you saying, well, if we've got more applicants who were above the line, we obviously look at them being available for Pembridge, and that our starting point is the unit is a commissioned service that if we have the workforce would be open. Our starting point isn't that we are keeping it closed to allow this review to happen. It is still closed because we haven't been able to recruit.
But is there a problem that everybody has? I mean, is this
Yeah, it's a national problem.
And a number of other hospices in North West London, that's part of why it's have been hard for them to support a network of consultants because they've also got their own challenges recruiting. So
I sense that's not going to change in the short term, though, is it?
that's why I'm trying
Kind
to
of
give false
emergency.
assurance that that's going to be an immediate solution because that is just the national and regional challenge.
We totally get that there's a recruitment crisis. However, I think that's going to be made even more difficult to recruit into this post, given the fact that the person who's going to be applying for it won't know if that unit's going to be open. We're not going to be able to recruit into a post if no
that's true.
consultant is going
Absolutely.
to find that enticing
Yes.
if they're going to be out of a job in 6 months. So I think you can't. It's like chicken or egg. Do you know what I mean? There needs to be clarity around what's happening to the unit in order for a high quality consultant to say yes, I'm going to go for this job. So
Yeah.
I don't think it's fair to say that it's just not finding a consultant that's because they are out there, even though there's a recruitment crisis. They are out there.
But we have tried to work with, because that was my first answer, was surely we have enough in our patch to be able to cross cover and support.
Yeah.
But we met with, and we even had a more recent, so that was before I went back, and then when I came back, we've even had a more recent within the last few weeks with our hospices that are still in North West London, still, you know, have an inpatient unit. And it's not possible for that at the moment. As far as we have got to, it is not possible for them to work with us on that. But it's something that we're not, you know, I've mentioned it again at meetings, I'll continue to mention it, because that was my first go-to. Why can't we just get cover from somewhere else, just to cover it? Can't everyone just chip in and do a few days at Pembridge alongside their usual job at St Luke's in Harrow or St John's in St John's Wood? And the answer was no. It was a resounding no. But they are around the table and they are interested in improving a model of care that they can deliver. And that's why, so I don't know if you've seen the Insight report, it is on our website as well. But for us during this process, we have made some quick wins. We have made some improvements for patients and the public in North West London. And I think if you look at that Insight report, it does list the things, it's like a you said we did. And I think that gives people reassurance that we are beavering in the background and doing things and improving end-of-life care and special palliative care whilst all this is going on. So it's not that total, you know, dead, nothing's happening while we're doing this. We are actually making change. We are doing things because I'm a doer and you know, we really want to try and improve what we can. And as you'll see as well, so page 14 shows you that the activity of community special palliative care has gone above and beyond, you know, 20% increase. So we are actually reaching more. We're reaching more, instead of I say we, because I'm part of the special palliative care and end-of-life care health professionals, but we are reaching more. We are doing more. We're seeing more. We just need to make sure that we're seeing the right people. We just need to make sure that we've made sure that everyone has that equity of access. And I think that you're right in mentioning about North Kensington, because that is that population that we need to make sure has the option of the inpatient, but taking into consideration that geographical. And that's why that patient experience is so important for me to really unpick. Because like I said, it's changed in my mind actually as to what people want and need, versus actually what now I understand to be what they want and need, which is choice, which is flexibility, which is other options of bedded care that may not need an inpatient specialist palliative care. They may need something else. So it's been heartbreaking to be part of this process, and heartbreaking in not only the emotiveness of end of life specialist palliative care, but also the timeline has been heartbreaking, because I know that it's just gone on, and I have to admit it, you know, like I said, I've been part of it from the beginning, but I truly feel we are moving somewhere. And as you'll see from the Insight, we haven't just done nothing over the last next couple of years. You know, we have been doing.
I move to Gerald and then questions to any other councillors.
But we were doing, did you have your, did the delivery group happen today?
Yes.
The delivery group was the first meeting of the Bioenvironment
Yeah.
delivery group for end of life care.
Okay.
There was such a really good stakeholders around the table, and people were really engaged and wanting to do stuff. And the actual group came out of, it's not existed before, and it came out of an exercise that we did at a North West London level to do a sort of self-assessment about what needs to be improved. So that was a real good win in terms of having something local to take forward some of those priorities that are outside of just the community specialist palliative care space.
Thank you.
Any other questions?
I just want to say one last thing, just in terms of the Pembridge beds. I think something that's really important to remember is that inpatient unit beds are very specialist need beds, and they have a set criteria to them, and they are for intensive support. So it's important to remember that the narrative there is, yes, somebody might want a bed, and a local person might want a bed, and they may want to go there, but that doesn't mean that even if there was a local facility that they would have access to it. And I think focusing on the fact that the model is going to provide more access to different things to serve more people's needs is the narrative that we really need to be getting out to the community, notwithstanding the emotional element of not having something necessarily local, if that's where we ended up.
Can I just
Yeah.
I think that's totally fair. point is that I wouldn't want us, and I know that's what you're doing, but I wouldn't want us to get into a situation where is it this improved community care or is it inpatient beds?
No, absolutely
it's
not.
both.
Yeah, you're right. It's
And-
both. It's both. It's both.
And yeah, I mean, obviously the beds are there for the people whose criteria, who've met the criteria for admission. Is that yeah, absolutely.
Thank you. Okay. And I think it'd be great if you could share those those piece of research with us, and also the end of care model. That comes out at the end of January.
Yeah.
Yeah, that would be great. And thank you so much.
Thank you.
Thank you very much.
Let's move to the safeguarding panels executive board.
Okay, fine.
So we're going to do safeguarding panels. Executive annual report. This is an annual report for the multi-agency board, which provides leadership for the adult safeguarding for Kensington, Chelsea, Westminster. 50% report is a lead
Thank you. Good evening, everyone. So it should have been Aileen Buckton, who's our chair of the Adult Safeguarding Board, but unfortunately she is unwell and we wish her a speedy recovery. But Louise is here to talk through the report, so that's good. Just a couple of things I'd like to say before I hand over. This is the 4th annual Borough Safeguarding Report, and obviously I'm going to say this is up to you to decide whether that's right or not, but it feels like it gets stronger every year. The reason I'm saying that and the criteria I'm using is that the service users involved in this, and they're heavily involved in putting together this report and in the board, are telling us that we are listening better and responding. Safeguarding is one of those areas you are never complacent. We are forever wanting to learn to be better. But one thing that is heartening from it, there are lots of things that are heartening from it, but one particular thing is that many of our residents from Kensington, Chelsea and Westminster, as this is a by-borough report, actually are representatives in London now. They have been, they've had a voice here, they felt they've had a voice, they've had training, they felt they've been able to influence some of the things that we do in the practice, and they therefore have the voice in London now and are training others, because it's such an important area that our residents are able to say the outcomes that they want at the outset of a safeguarding, and then to determine whether we have done a good job, and that is all the partners, not just the council, in supporting those outcomes to be achieved. So the fact that they're that is we're very proud of. So I think that's probably enough for me. I'll hand over to Louise.
Thank you, Bernie. So just picking up on the same line before I actually make a start, I'm really keen that you're aware of the fact there's actually an online version. This is the 2nd year. And just to pick up on what Bernie was saying about those service users, if you look at the videos, and I'll just point them out, it really brings the whole report alive and it makes it 3-dimensional. And you can actually really see the evidence of us engaging with service users. So even though I'm talking to you 2-dimensionally, it's really the online version that I'd like to draw your attention to. So yes, I'm really sorry that Aileen Buckton is not here today. So her forward really brings across 3 key messages. And the first one is that we've got an ongoing commitment to really looking at the challenges and opportunities coming out of COVID. That's still really key to what we do. The second part of it is the fact, and it sort of leads on from this, is we really want to continue to ensure that we're making safeguarding services accessible to all. What that actually means in detail, it's not just about overcoming language, it's not just about ethnicity, and it's not just about disability barriers. What we're actually trying to demonstrate through the evidence in the report is we're really grappling cultural perception of the residents and the communities around what keeps them safe. And I'll talk a little bit more about that in the report. The Stay Safe project, which I will talk about, is actually seen as trailblazing. We'll come to that in a minute. I also wanted to say that the report, I hope, reflects really well the cross-department working with housing, with children's, with community, and in particular what I want to talk about in the report is the fantastic work we're doing around self-neglect and warding, particularly with Doug Goulding, the Director of Housing, and I just want to pick up on that further in the report. in the minute, because it really does demonstrate some fantastic work that we're doing. And then lastly, just going back to our lovely service users who actually for the first time have consented to their faces being on the report. I just want to actually thank ADKC who host our service users, and they're instrumental in providing the space and the coffee and the buns and things and the biscuits in order that we can really engage with Shiv, with Michael, with Hasina and with Faye. So if I just draw your attention to maybe just about 5 areas of the report. I have got some harder copies and one that you've also got some as well. And then very happy to answer any questions. So, as Bernie was saying, the Safeguarding Ambassadors are in the first chapter, so to speak, and their voice comes out very strongly. Maria Stover is a fantastic chair. In fact, we've literally just had Safeguarding Adults Awareness Week, and she's been instrumental. They've all been instrumental in co-producing the events that have been out and about, and I think that was an appendix you might have got after your actual report. Picking up what Bernie was saying about service users, the video of Glenda, which is on page 17, is really interesting to read because it demonstrates where she's come on her safeguarding journey and the fact she now is the face of London Voices, where she's actually instrumental in actually driving forward strategically where service users sit at a London-wide level. So we're really proud of all the work that Glenda's doing and how much support she's actually giving us at a board level. Now, I did actually mention the Staying Safe project. It's the advocacy project who are actually commissioning to do this piece of work. And this is the second year in which we're really trying to reach out into the hard-to-reach communities in Kensington and Chelsea and Westminster to really hear the voices of people who we don't normally hear. And one of the reasons is the language barrier. And they've been very explicit. They've been saying, we don't want you, the council, to engage with us at this moment in time because we are still fearful. Not only might you take and remove our children or our elderly parents, we want to hear what the advocacy project have got to say first. So we've now moved on from there, and they're now saying, actually, we do want to engage with you in phase 2. We'd really like to put a name to your face and just hear what you've got to say. So we're really moving forward in terms of understanding who these hidden voices are, the issues that they see around their own faith cultures or their own communities when they feel fearful about raising incidents of abuse or neglect, around the repercussions that they might have within their own community. So it's a really interesting project, and it's a project which actually has been picked up by some other councils who really feel this is something that they want to begin to grapple with as well. So that's one of the key areas that's come out of COVID recovery in terms of really reaching in to understand what our communities are actually thinking and saying around safeguarding. So I won't talk about that in any more detail. I just urge you to read the actual report itself. So then what I'd like to come on to is something that we're really, really proud of on page 40, and that's our outcomes. If you had time to go back and have a look at the other 3 reports, you'll actually see that the evidence is demonstrated in the fact that particularly in RBKC, last year 89% of people stated that yes, when the incident of abuse actually occurred, they were spoken to and they were asked about what do you want to happen next. That has now improved up to 95%. We really are hitting some extraordinary targets here. And what this is demonstrating is the fact that our social workers are actually talking to people. They're actually saying, this incident has occurred, how can we help you? How can we support you to feel safer in your community while this incident has actually occurred? And that is the key to making safeguarding personal. So we've got some great evidence here to demonstrate that we are really doing very, very well in that area. But it's really important not to sit on laurels at all. And I think on page 43, I just wanted to highlight, well, 2 things actually, before I talk about the great work we're doing with Doug. We decided to focus in on 2 areas of abuse types, and one of them was financial abuse. I think the economic crisis really began to pick up into it last year, and we really wanted to make sure that our safeguarding ambassadors and indeed our communities were actually supported and just trying to understand how they can support themselves, particularly around cybercrime. I mean, if you remember COVID-19 and vaccinations and scamming, it was absolutely rife. And the video, which I can't show you, but I'd really urge you to have a look at, is one on 45 with Shiv and Michael. They're elderly people talking to elderly people about how to keep themselves safe online. And I've learned something from what they've been talking about. It's a top 10 tips, and it's been done in a way that's hopefully engaging to watch, whereby it's not scary. I mean, they were terrified to begin with, but it's not scary. It's really been, it's just 3 minutes. And I think if there's any one video you want to watch, I'd ask you to have a look at that one. But if I just come on to the work that we're doing with Doug, interestingly enough, RBKC has got a really high instance of self-neglect and hoarding cases compared to maybe some other London boroughs. And Doug really wanted to understand, well, actually, what does this actually mean in practice? And we did a bit of a scope out, and in fact, Chelsea and Westminster Hospital also stated, yes, well, that's really interesting. We get actually quite a high percentage of self-neglect cases that come through our doors as well. So Doug has, for the last about a year now, set up like a strategic group to unpick this. And we're not there yet, and this is where we don't sit back on our laurels. It's a very challenging piece of work to do. And he has been instrumental, though, in pulling together housing, so not only his own housing, but housing needs as well, pulling together hostels, pulling together general stock housing within RBKC, and we're now pulling together the registered social landlords, which I can't rattle off, but it's about 7 or 8 of them who we really want to engage with. You know, your Nottingham Genesis, your Cyrerians, your Women's Pioneer, all those housings, we want to engage with them as well. So actually it's a community partnership feel to hoarding and self-neglect. And he is brilliant at holding our attention and really focusing and pushing forward with coming up solutions. Next year's report will actually have a much clearer idea about actually where we are with this and the challenges that he's grappling with. And we know that in Kensington and Chelsea, there are many single people living in their own home. He also talked about the fact that the flats are quite small and there's quite a lot of balconies. So he's talking about creating much more space in the communal areas and what that might look like. So there's some things that he's thinking about sort of as a quick win, but actually there's a longer term planning that we need to do to support adult social care who deal with the most challenging of these cases, and that's having much more of a psychological input into actually what's happening and actually ensuring that they've got a bit of a budget to ensure where to go and how to manage some of these cases, because you need partnership wrapping around them. It can't just be a quick sort of engagement. It needs to be really over really many months in order to really understand what's taking place. So that's some very interesting work. The last thing I need to draw your attention to, when I say need, the annual report is a statutory document which we have to produce by law. We also have to, a little bit like children's, undertake safeguarding adult reviews on those cases where it's been identified that a multi-agency working could have been better. Okay, and so on page 64 we have the case of Joan. Now Joan is actually her real name, and we got consent from her brother, from her granddaughter, and from many family members in order to engage with them to understand where things went wrong, what it felt like for them in things going wrong, and how we might actually put things right. So I think what we've used is the word Joan's legacy here, and that's their terminology. And in next year's annual report, we have a really emotional but heartwarming and brave video of Leslie talking about her experiences of engaging with multi-agency providers who were looking after Joan and how she was feeling about that at the time. And this is one of the first times that we've actually engaged with a family who felt really quite distraught at some stages. And it's I'm almost lost for words because it's been a very difficult engagement exercise. But she now has engaged recently in the CLCH annual safeguarding forum which they have, and she actually spoke to about 60 or 70 people online about her experiences on behalf of the board, and she has actually said yes to everything we put in this annual report to do with Joan, and wants to, because it's over 2 pages, and wants to continue to support us to learn from families when there's been a fatality and where multi-agency practice could have done better. So we are really learning, which is what Safeguarding Adult Reviews are all about. And then the last page is just a really big thank you to the Safeguarding Executive Board, which is a partnership response to safeguarding adults. I'm very happy to take any questions.
Thank you so much. And I completely agree. I think it's amazing to have all the infographics and videos that bring it to life. Sure, it took lots of time. So the team. Anyone wants to start with questions? I have one. I know you mentioned sort of fraud that's going on at present, and I was just wondering in terms of our elderly population, which you just referenced the video, there was an advert recently that I saw last week in the council on Nextdoor, but how are we reaching residents who might not be on their phones, seeing these types of ads, and how, I mean, this fraud kind of rolls daily as to what people are doing. So, and now will be some of the most vulnerable to these types of scams. So I was just wondering just what's the council's safeguarding?
So we do everything in partnership. So when I talk about fraud, it's us and trading standards. So we work closely with them, and the council actually goes and knocks on doors. They'll actually go and knock on the door if they feel there's a vulnerable adult sort of who might be exposed to, as you say, letter dropping. Also, if they actually do receive care and support, we ensure that our frontline staff, our social workers, or our independent living assessors are aware that when they open the door or look through the letterbox, if there's a whole load of piles of envelopes stacked up in the corner, which you can see a lot, then it triggers what they need to do next. So what I'm trying to say is, once again, it's a partnership response. We work really closely with trading standards. They work really closely with us. And our information advice teams in particular, if the case comes to their attention, will go out and knock on the door if a neighbour or if a tenancy support worker or somebody from housing might say, I'm a bit concerned about Mrs. So-and-so, she's just appearing a bit withdrawn recently, then we will go out and knock on the door and just ask, if there's anything we can do to help.
Can I just add something really quickly to that, which is, Louise talked about partnership working, and of course you've seen from the board it's essential that you do partnership working, but what we've understood over the years is a patient, a resident, someone may approach someone about multiple issues. So they may not be approaching someone about fraud. It may be that they have a clinical issue or they've got something else going on. In order to have the whole partnership understanding about fraud, it's really helpful, because depending on who they go to for their primary need, if they then mention something about they're worried about financial abuse or fraud, the individuals and the professionals, and there are a broad many of them, can actually answer on that as well. So it's not just the one dimension, your council officers or fraud officers can answer, it's a much wider, and that's the benefit of the wider partnership, that everybody learns. You've got your specialisms, of course you do, but you learn everyone else's so that you're able to respond to the residents.
Thank you.
Thank you very much. Thank you for the report. It's an excellent report. Thank you. Just want to look at the modern slavery part of the report. Just I don't know how long that's been part of the report, whether it's an emerging thing or. And there's a slight question: is how do we get to those people? How do we understand? I remember when I first became a councillor, I went to my vicar, the local vicar, said, "Could you introduce me to some isolated people?" He said to me, "Well, councillor, if they're isolated, I probably don't know them." And there's an element of that, isn't there, within this modern slavery issue?
Okay, so in fact last year's report had a much bigger article on modern slavery, because this year's report is something that our local account group wanted to understand a bit more about. So again, the Safeguarding Adults Board delegate to violence against women, which sits in the community safety agenda, all the systems and the responses and the checks and the monitoring around modern slavery. But in answer to your question, adult social care are the first responders. So all our frontline staff are trained in a little bit like Bernie was just saying a minute ago. If somebody telephones, it's like not just hearing what they're saying, it's hearing probably what they're not saying. So in many respects, it's normally out of hours. So our out of hours services, UDT, might pick up some of these modern slavery queries, either from a third party or actually people calling up themselves. And we have a very clear system in place. We actually have a modern slavery coordinator who's actually paid for by RBKC. We have very clear systems in place. They're very robust systems. We work very closely with the police. We work very closely with the voluntary sector because a lot of it's got to do around housing. And it's much more sophisticated now than it used to be. But if you'd like to know more about it, I can certainly provide more information for you. But this year, we didn't really touch on it as much as we have done in the past, primarily because last year we actually did quite a large set of articles about it.
But you are right, Councillor, it is newer to the safeguarding world, modern slavery, like hoarding, that wasn't there kind of at the outset when we used to think about safeguarding, but those kind of more broader areas are now seeing themselves as under safeguarding, so it's a wider remit.
And actually reading that report, I was surprised how wide the remit was and
Yes.
the different issues that are in there. So
Yes.
Thank you. Yeah, first of all, this is a really impressive report. I thought it was absolutely brilliant. There's just so much rich information in here, which is really valuable. The question I had was just about what challenges you faced in terms of interface with other agencies, particularly thinking about mental health services, in particular what challenges there have been in that specific interface, because that's obviously a priority for us, and also thinking about the increased need for mental health services that's happening now in the context of cost of living.
So what I'm going to do is I'm going to introduce you to David Bellow, who's actually head of our mental health services. But before I do that, can I just say, before the pandemic, it was really very challenging. The pandemic really meant one of the fantastic things about that situation, which was pretty horrendous for everybody, is that the partnership came together. So I just want to make that point. But I think, should I hand over to you, David?
Yeah, sure. Yes, thanks. Good evening. Again, I think we've discovered that there's an increasing need for kind of services around mental health population due to COVID, the pandemic, and also due to the kind of effect of the cost of living crisis. So what we've done recently is that we've done a mental health position statement where we've kind of spoke to communities and also spoke to CNWL partners to just understand what are the core issues, where are the gaps, where are the referrals coming from, and where are the needs that we need to try support with. And we also did a market stall at Portobello Road. I was there, listening to people. It was a pop-up, store, wasn't organized. And we met over 60 residents that actually came to us, asking questions. Some of them actually gave us some concerns that they have, in terms of the gaps in mental services. So that has helped us as we're moving into developing a mental health strategy. And that is part of the work that we're doing in partnership with community organizations and CNWL and also colleagues within the local local council.
Is there any, just conscious we're a bit behind on time, but any questions from councillors or thank you guys so much for this very helpful report. The next report provides an overview on the council, on what the council is currently doing to promote healthy weight in Kent University. I'd like to invite Councillor Alan Brooke, Anna Raleigh and Sarah Crouch.
very much. My name's Anna Raleigh, I'm Director of Public Health in Wheelbarrow, and I'm joined by my colleague, Deputy Director Sarah Crouch, who is our lead on healthy weight, and also Councillor Attenborough as our cabinet member. There are 5 key points that I'd just like to pull out as an introduction to our paper, because I know you will have the opportunity to read it. So what we've tried to do with this paper is to set out why healthy weight should be a priority for RBKC and the size of the problem locally. Next to smoking, obesity is the biggest contributor to the burden of disease. So in terms of the driver of long-term conditions. So therefore it is really important in terms of prevention that it's a key area that we focus on and we're aware of. And given the size of the problem in London, as the city with the largest rate of childhood obesity in the world, the fact that we sit alongside that on the London average is no comfort to us in terms of reassurance that we're on an average. It's not a good average to be on. Our strategic approach is very much maximising some of the cross-cutting themes. So where there's an opportunity to focus on obesity, we also have wins by focusing on sustainability, by focusing on pollution, by focusing on climate change, etc. So our approach has very much been a whole council approach, galvanising the work across the council in this area and those cross-cutting themes, as well as a whole systems approach, because obesity is a really complex problem and there's no silver bullet, there's no one intervention that's going to be effective. It is about galvanising a system to come together all at the same time to make their contributions. In terms of what's working, we've pulled out things about the very specific approach that we've developed here within the Royal Borough, and that is very much a grassroots, community-led approach, listening to what our residents are telling us, understanding what their barriers are locally to accessing healthy food, to eating healthily, to physical activity, and then working with them to develop solutions and taking forward that more neighbourhood, place-based approach. Alongside that, we're also very much targeting some of the key at-risk groups, because there are certain groups that are disproportionately affected and will need more support. So we're particularly thinking about those with physical disabilities. We've got some really innovative practice in RBKC for those with learning disabilities as well, alongside people with mental health problems and mental health and weight, or intrinsically linked as well. Also specific challenges around older people and certain ethnic groups and women, as all groups that are at high risk around healthy weight. In terms of our work ahead, there's more that we need to do. So we're currently reviewing our services. We'll be going out to recommission services next year. So there's a real opportunity now to pull together our understanding of the problem, what's come up from community sentiment and what we've heard from local people to inform that. We're also very aware that we've entered a cost of living crisis since we've really defined our strategic approach in this area. So that's requiring a different intervention and a different solution as well. So we've tried to pull out some of the work around that. And then my 5th point is very much thinking about how we're measuring some of this as a system and finding more effective ways to measure what we're doing. So there's something around measuring acceptability. Are we doing what people asked us to do? So can our residents see what we're doing? Are they finding it effective? Are they engaged in what we're doing? There is something around effectiveness. Are we getting population health impact? Are we reaching the parts of our community that we want to reach? So in terms of getting an equity of service across our system. There is also something around, is the system working better together? And the new Healthy Weight partnership that we've developed, I think, is galvanising the system in a way that we haven't before. So in terms of NHS colleagues coming together with us as a part of our place-based approach, alongside the work that we're doing in the council around environment, around place, alongside our voluntary sector and our community services. So happy to take any questions and over to the floor.
Shall I start? Okay. You mentioned, I mean, what comes across really well in the report is just how serious this problem is. A lot of information that I wasn't aware of, like the rates of child obesity in Goulburn being the worst 2% in the country, and other figures like that that were really concerning. And I totally understand what you're saying, that there isn't one right answer. It's a very complex question, but there are things that we do know. So we know that food poverty and food insecurity is a huge driver for obesity. And you mentioned cost of living, but I guess what was a little bit worrying from the report was how little time was dedicated in thinking about solutions for that. So the only thing that's mentioned in the report for addressing food insecurity or food poverty was ensuring that those families that were eligible to Healthy Start claimed their vouchers, and not even 100% of, just sort of aiming for 75% of people who are eligible to claim their vouchers. So I guess what else is being done to, because this is only going to worsen, if we know that food poverty worsens obesity, the next couple of months is just going to exacerbate the problem. We'll be going the opposite direction potentially. So what's there being done to sort of help support families in that regard? And then also to think about food environments, really, because we know that there's a lot of evidence that the way in which food is advertised and the practices of retailers and manufacturers and advertisers have a big impact on people, the choices that people make. And there's a lot of evidence that actually local authorities that have clamped down on the way that food is advertised and displayed and so on actually does reduce the number of calories people are buying each week. So and that this has a bigger impact for in areas that are socially deprived as well. That has a bigger impact there. So yeah, those are the two things that I wanted to ask about, and also the fact that this is a very difficult question and it seems to be getting worse rather than better. So what needs to be thought about differently, and whether what we're doing is evidence-based, because a lot of the solutions seem to be about changing individual practices as well, which we know doesn't work.
So I think really important questions, and very much that socioeconomic gradient around obesity is something we're really aware of, and it's very much driving the work that we're doing. I'm going to invite Sarah to sort of comment on the particular neighbourhood approach and the work there that's looking at the wider environment. So I think it will cover what you're asking around support for family, but also around those food environments as a part of that place-based approach. And then we can talk about some of the new opportunities.
Yeah, sure. So really important question, I think, and something that we're taking very seriously. We have got a work stream specifically on living standards and one on place. So this very much emphasises the fact that it is that holistic view, trying to not just look at services or behaviour changes, it's trying to widen our reach. So I'd say that the three things that we're doing is firstly understanding the assets at a very local level. The second thing is trying to understand the place and how we can change it to address food poverty, and then looking at sort of specifics around the living standards, and that's where Healthy Start comes in. So understanding assets, if I put it in practical terms, as far as what we've been doing in Chelsea Riverside, around the World's End Estate as an example. So we've been engaging with residents to understand a big thing that came up was around not being able to buy fresh fruit and veg. The local co-op there is really expensive. It's sort of one of those local supermarkets, so it's much even more expensive than sort of a normal supermarket. And there's not much else available. So we've been trying to look at what would work for residents rather than just assuming that we know. So that then is focusing around food cooperatives. Is that an option? There's a convenience store on site, so we're looking at rather than sort of taking away business from that individual, can we review what provision is put in that convenience store? Is there possibility to put a market in the piazza? These are all things that we're exploring to try and make sure that there's a foodable fruit and veg and wider access to healthy food. The other thing, so that's the place bit, if you like, that's trying to change the environment that people live in so they've got better access. The living standards aspect is, yes, Healthy Start is only one small benefit. We have been working very closely with colleagues around the cost of living challenge generally, and trying to think are there ways that we could think about training frontline staff around, particularly health staff, around financial resilience and advising residents on what benefits they might be able to gain. Are they maximising their income? Is there any other access to support that they could get? So that's another aspect of working in partnership with others. I think it is a very challenging situation, but we had a meeting on Friday to discuss with a cross section of officers from across the council kind of what else could we do that is very much about addressing food poverty, addressing some of the wider concerns that communities have around all of these issues which kind of combine, and healthy weight is one outcome that we'd want to influence, but equally mental health is another.
Can I just jump in there? When we did the Go Gordon project, one of the things that we learned there was that kids would come out of school, they'd go into the local shop, Sunny Delight, all the rubbish was by the till. So we worked with, shopkeepers and said, could you put them in a different fridge? Could you put that? Could you put fresh food? And it did make a difference. So I think there's a big piece of work still to do around that, because I think it's with COVID probably that disappeared a bit, but certainly it was effective.
Jack.
Thank you very much for this report. Do we have any evidence of the impact of all the initiatives that have gone on beforehand? So, for example, I know you're a bit on evaluation metrics, but do we know that as a result of all the stuff we've done in Goulburn over the last 5 years, 8 years or whatever, that it's not 46% now, it's 38%, or what's the...
It was about 2%.
So all these initiatives that are going on, which are great, are we seeing the impact of them in raw data?
But this is different. I mean, that was Goulburn, I think it was something like 2%.
Yeah. I'm just wondering, there's a lot of initiatives here which are really great. When will we see the impact of them, and how will it be measured, and what will the data be?
Yeah. Do you want me to take that one? So again, looking at a neighbourhood level, what we're trying to do is understand where the residents feel, because it's not just about have people lost a set amount of weight. That's not the only thing that we want to look at, because I think it's a journey. It's like quitting smoking, isn't it? That people may not quit smoking on their first attempt, but over a prolonged period of time, they'll succeed. So what we want to do with our approach to the neighbourhoods is to work with communities to understand what success looks like for them. So we're looking at improved quality of life, we're looking at mental health measures, we are looking at weight and monitoring that at a whole borough level as well as at the individual neighbourhood level. We are looking at will we influence attitudes, will people feel more capable, and for example in the example that you just used around food poverty, will people feel that fruit and vegetables are more accessible and affordable for them? Will we influence attitudes and behaviours around healthy eating? Do people feel more confident to have a conversation if they're a GP and working with that population? So we've got a set of metrics which will look at what we're monitoring at an individual neighbourhood level, and then monitoring the overall things like breastfeeding uptake, childhood activity, activity. Are we changing the number of people that are doing more than 30 minutes activity a week, which is a really key measure. So we have got all of those in place, and the benefit of this programme is it is in partnership not just with the council but with the voluntary sector and the NHS, and so I think what we're trying to do with our services is get data from every place, not just the council commissioned services, and that will also add to our data on are all the services collectively, even if we look at the Diabetes Rewind programme or the more specialist weight management services, are they achieving successful outcomes, and are they achieving successful outcomes for all of our residents? So that would think about the high risk groups. Are all our services accessible for all groups from any community? But those are the
What's
measures
the
that we're
overall?
looking at.
What's the overall target here? If it's obesity, is it that in 10 years' time, 10% of our population less will be what's the ultimate measure?
So I guess the key measures that we sort of focus on from that level is we measure our children when they enter reception, sort of when they leave reception as part of the National Childhood Measurements Programme. So that's a very important indicator for us in terms of understanding trends and sort of direction of travel. For adults, we have a number of different things we look at. One is there are the wider national surveys, which give us a guesstimate of our population level. And we've been working very closely with GPs to get real data from GPs and to support GPs to develop registers for people who are overweight and to ensure that they're having those kind of regular conversations with people. So that's given us the figure that we've included in the report around the 1 in 13 being overweight and or being clinically obese, sort of on that GP practice population. So we haven't set a specific trajectory. We haven't put a number against a trajectory sort of at a local level, but they are trends that we're monitoring. But going back to your point about what do we know works for obesity, what we know works is working at that whole system level. And we know it's not just doing weight management services, because you can't direct people into services and then send them back into communities that don't support that, and send them back into places that don't make a healthy choice the easiest choice. So it is around adapting places, changing those social norms within communities, and then ensuring that people who need that extra bit of support to enable them to make that lifestyle change habit. But it is about galvanising the system to all be targeting their efforts at the same time at this really complex problem. And that's what we're trying to do.
So maybe I'm missing the last bit there. Or if all that's great, if we eat healthier, if we do all those things, surely it's about reducing obesity at the end of the day.
So then we'll start to see those trends come down. So we know that particularly around childhood weight management, COVID has been quite a challenging period. We know that people have been less active. We know that's the case for children, and we know that will be the case for adults as well. So if anything, what we've tended to see is this kind of increase over the very kind of unusual 2 years we've just had. And now there's an opportunity as people have come out of that kind of acute stage of the pandemic to do a bit of resetting and kind of rethinking and focusing. So that's why, figures aren't as easy to understand at this point in time, because of the very unusual 2 years we've just had.
I was just going to ask, in terms of in the school holidays, are we using facilities within schools and locally to, I know there are lots of wellbeing events that are going on, but I don't know, I mean just in terms of keeping kids active in the school holidays, and we have lots of amazing facilities across the borough, is there a way to utilise those, and are they being utilised so that kids can still be active in the same way?
So I think some of the schools are, aren't they?
Yes, so there's a holiday activity fund where there's a whole host of different activities going on, and this summer we have also held a lot of pop-up events at different places. One of the key bits that we want to do going forward is put schools much more at the front and centre of this and empower them, so it's not just about kind of prescribing, again, sort of here's the evidence base, this is what you ought to do. It's also about listening to what the children say is important. What do they think is going to influence more children walking to school, for example, or healthier options for them. So that's really where we're going for. And with the Healthy Schools approach that we've got pretty much all the schools signed up to, they also get lots of support from our Change for Life service, so around school menus and encouraging sort of vegetables intake and sort of, especially going back to the cost of living crisis, making sure that those standards continue to stay high. That's a really important part of our service.
Yeah, I'm just thinking about a study in the BMJ from last year, which showed that for each sort of 10% cut in Short Start Centre funding, there was a worsening in the prevalence of childhood obesity. And I guess what's being done to mitigate the withdrawal of those sorts of services, because we know that that's something that worked to keep young children healthy. And also just thinking about something else that we know works, the local authorities up and down the country who have clamped down on the way in which unhealthy food is advertised. That's, again, especially in socially deprived areas, has been reflected in reductions in the number of calories that are bought and the proportion of kind of salty and fatty foods that's, I mean, those are things that we know work. So is there scope to kind of replicate that?
So on the second question first, because sorry, I didn't come to that when you asked it the first time around.
Yeah.
We are working on the advertising policy for RBKC and making sure that where there are levers locally, that we take into account all of the learning from the TfL ban. Absolutely. We've put in one of our ambitions is every hospital community hub to provide healthy, affordable food and water and opportunities to be active, walkable neighbourhoods and infrastructure that supports active travel. So we want to go further than that because I think the council only has limited levers in terms of those advertising bans, how far that will cover. So again, trying to think about where people are. If they walk into a hospital, are there healthy options available to them? Are they the most obvious options? Are they the cheapest options? And we've been having conversations with the Health and Wellbeing Board about how we can sponsor that kind of approach right across the board so that we have a much wider range of healthy settings across the board. So that will add value to any advertising policy in addition. And the other question was about, sorry, just to Short Start. I think again, it's what we are focusing on is what we have, the assets that we have in communities. You know, if you take the 6 target wards that we're focusing on in RBKC, it's around the north of the borough and the south. So we have mapped out with communities what are the places that they value, what are the places that they go for children and families and adults. And that is helping us to understand how can we think about activities that might go on in those areas. How can we add expertise through our services to ensure that whenever somebody goes into those settings, they're also kind of giving the opportunity to think about healthy choices. So, for example, the Dalgarno Centre does loads of brilliant work. They've had a Change for Life grant. They've done really fabulous engagement work around Zumba, healthy eating, intergenerational cooking. We've done some sessions at Al-Manar Mosque. It's really trying to understand where we're likely to have success and not just relying upon one specific setting. That's how we're trying to widen the reach to everybody.
Last question.
Thank you. Just checking it wasn't anyone behind me. Thank you, Chair. 2 really quick points, if I may. One, obesity is such an important area, and I wanted to make sure that the committee know that as part of the place-based partnership, which Janet and I are a representative from Health and from the Council, it's wider than that because it's also got CNWL and CLCH, but it's where we discuss local issues as part of the big integrated care system. Obesity is one of the priorities, just so to learn that. And the second point is, the piece of work we've been doing in talking to communities and talking across health and social care has said obesity is so important, but the residents are saying, can you not just look at obesity in isolation? Can you look at it alongside social determinants of employment and education and housing, because those really do impact on obesity as well. So we're trying to make sure we've got the programme, but we also look at these determinants as well and see the impact.
Thank you. Thank you,
Thank you very much.
So our final agenda item is the work programme towards change. Scrutiny policy.
Thank you, Chair. So this just briefly sets out the remaining items in the work programme for the rest of the municipal year. We have 2 meetings left on the 27th of February and the 2nd of May. I think you should note as well you have got capacity left for other items. I think we should include those as well. The report highlights 2 areas where you may want to include a report in 3.3 around winter pressures. And also in 3.5, the NHS have been in contact with the committee about another change proposal they have around inpatient orthopaedic surgery and a proposal to open a centre at Park Royal Hospital site.
Thank you. Is there anything that you guys would like to bring the committee there? In terms of,
So we don't have anything scheduled for the mental health strategy work that's
because that's the second strategy, is that what's the date that will be?
Yeah, sure. I think, this is for next year. I think,
Yeah.
we did discuss previously that, yes, that will bring this back in the new year
Okay.
when it's published, yes.
Would you have a date as to when it will be published?
We haven't found a date yet, but we're looking at in the middle of January towards the end of January.
Do you think it could come to the February meeting?
Yeah, absolutely, yes.
I think that would be great if we could aim for that.
Okay. And is the committee minded to have a report on winter pressures for the February meeting as well? Is that
Yeah, I think
the committee?
that's a good idea. I think that's agreed. Do any members of the committee have any questions or comments? Oh, sorry. Thank you everyone for your time.
Thank you very much.
Thank you.
And it's nil.
I don't know.